Hey everyone, welcome to this explainer. Okay, today we are jumping right into a highly focused, rapid-fire clinical review tailored specifically for your nursing exams. We're taking a deep dive into neuromuscular pharmacology. So we're going to break down the complexities of these meds, look at the exact nursing assessments you need to prioritize, and absolutely tackle those critical black box warnings that you literally must know for safe patient care. Get ready to focus because we're packing a ton of high-yield info into this session. Here's our clinical day-in-the-life roadmap. We'll kick things off with neuromuscular and EPS prep, move to benzodiazepines, distinguish central from peripheral spasticity, hit GABA analogs and MS immunomodulators, and finally wrap it all up with toxicity triage and those black box warnings. Okay, Section 1, Neuromuscular and EPS exam prep. Let's dive right into this. Let's activate your critical thinking right out of the gate with a super common assessment priority scenario. Picture this. You walk into your patient's room and you observe this highly specific extrapyramidal symptom. We're talking severe, painful spasms of the neck and the body that literally force the patient into a rigid, arched position. So, what's the clinical term for this? Take a second and lock in your answer.
If you said dystonia, you are absolutely correct. Dystonia is a form of acute EPS featuring intense muscle contractions. It causes these repetitive movements, unexpected head tilts, and those painful arched postures we just talked about. We frequently see this in patients with cerebral palsy, but remember, it's also a hallmark acute extrapyramidal symptom, or EPS, triggered by certain medications, like in Parkinson's treatment. And what's our go-to antidote for this terrifying reaction? Well, that would be benztropine. It's an anticholinergic medication that just calms all those wild extrapyramidal movements right down.
Moving right along to Section 2, benzodiazepines, rules and reversals. Okay, here's your next practice scenario. Your patient is prescribed diazepam. Two things you need to know. First, what is the telltale suffix that helps you instantly spot this drug class on an exam? And second, knowing exactly what this drug does to the central nervous system, what are your absolutely crucial nursing assessments? To answer that, you really just need to remember this vital mnemonic. The suffix you're looking for is typically PAM or LAM. Think diazepam or lorazepam. And the golden rule? Benzos means low and slow. Because these are CNS depressants, absolutely everything drops. You've got to assess for a decreased respiratory rate, lowered blood pressure, and decreased GI motility, which, yes, means profound constipation. Remember, benzos at bedtime. Also, you have to monitor for tolerance and dependency, since these are strictly meant for short-term use. Now, the physiology behind that low and slow effect is actually pretty fascinating. Benzodiazepines work by boosting the effects of GABA right at the receptor level. When the drug binds, it's basically opening the floodgates for a massive influx of negative chloride ions to enter the neurons. This rush of negative ions causes greater neuronal inhibition. In plain English, it drastically reduces muscle overactivity, which eases stiffness, but it also causes that profound central nervous system depression we just talked about. And because of that intense CNS depression, you always have to be ready for toxicity. So, here is your rapid-fire triage guide if you suspect a benzo overdose. Step 1. Identify the clinical signs immediately. You're looking for severe respiratory depression, profound hypotension, and bradycardia. Step 2. Quickly prepare the specific antidote, flumazenol, for IV administration. And Step 3. Closely monitor the patient. Reversing the drug too fast can actually trigger acute withdrawal manifestations, and that includes life-threatening seizures. Enter flumazenol. This is a competitive antagonist that can quite literally save your patient's life. But I want to pause here and really emphasize something critically important. The FDA has a severe black box warning for all benzodiazepines. The danger of toxicity and death completely skyrockets when these drugs are mixed with opioids, alcohol, or illicit drugs. As a nurse, catching and stopping this lethal combo before it happens is absolutely your highest priority. All right, Section 3, spasticity, central versus peripheral. Time for a high-stakes exam question. Say you have a patient with severe muscle spasticity. Which muscle relaxant absolutely requires you to draw baseline liver function tests and then continue periodic liver enzyme monitoring throughout their therapy? And this brilliantly illustrates the answer. Let's compare our centrally acting drug, baclofen, with our peripherally acting drug, dantrolene. Baclofen acts up in the CNS as a GABA B agonist, so its main side effect is drowsiness. But dantrolene, it works peripherally, inhibiting calcium release right inside the muscle itself. And check out that major adverse effect for dantrolene, severe, potentially fatal hepatotoxicity. So dantrolene is the drug that mandates that strict, ongoing liver enzyme monitoring. Let's look just a bit closer at baclofen. For severe spasticity, like what you'd see in cerebral palsy or spinal cord injuries, it's often given via an intrathecal pump. This tiny catheter delivers the medication directly into the fluid surrounding the spinal cord. It's a game changer because it acts exactly where it's needed, which means we can use much smaller doses and avoid those widespread full-body side effects. But having a mechanical pump introduces a really terrifying emergency risk. If that pump malfunctions, or say the battery just dies, you are facing a massive black box warning emergency. Abrupt discontinuation of intrathecal baclofen sets off a lethal cascade. We're talking high fever, altered mental status, exaggerated rebound spasticity, and severe muscle rigidity. And if that's not caught, it rapidly advances to multiple organ system failure, rhabdomyolysis, which is the literal rapid breakdown of muscle tissue, and ultimately death. You have got to educate your patients to never, ever miss a refill appointment for their pump. Moving down our clinical pathway to Section 4, GABA analogs for neuropathy. Let's do another practice scenario. Your patient with peripheral neuropathy is starting gabapentin. Think back to the contrast we established a minute ago. Which specific organ function must you prioritize for assessment before and during this therapy? Well, unlike dantrolene, which goes after the liver, your priority assessment for gabapentin is renal function, so you're watching the kidneys. Interestingly, gabapentin is structurally similar to GABA, but it actually modulates calcium channels to dial down excitatory neurotransmitters, which calms the pain and spasticity. Because of how the body processes it, strict renal monitoring is a must. Also, a quick side note, you absolutely must screen these patients for depression and any history of suicidality, as those are major contraindications for this specific drug. Now for Section 5, managing MS with immunomodulators. Multiple sclerosis is a super complex condition, and the medications for it are total heavy hitters. Your patient is prescribed interferon beta-1a to reduce their MS exacerbations and try to slow down physical dysfunction. Since this is an injectable drug they'll be taking at home, what essential self-injection and safety protocols do you need to teach them before they discharge? For self-injection, you've got to teach strict asepsis. Cleaning the work surface, washing hands, using alcohol pads, the whole shebang. You also need to remind them to rotate injection sites to prevent long-term tissue damage. But arguably the most highly tested safety point here is sharps disposal. Used needles must immediately go into a puncture-proof container. You literally have to explicitly tell them to check community guidelines for hazardous disposal, utilize community drop boxes, and absolutely never, under any circumstances, throw these into the household trash or recycling. Finally, let's wrap it all up in Section 6, Toxicity Triage and Black Boxes Review. Let's bring everything together by reviewing the most critical contraindications across all these drugs. It's essentially a tale of two organs. Hepatic impairment, meaning protecting the liver, is your absolute priority when administering dantrolene and MS immunomodulators like the interferons. Hepatotoxicity is a massive risk right there. On the flip side, renal impairment, protecting the kidneys, is your primary concern and priority assessment when your patient is taking gabapentin. Keep these two distinct pathways separated in your mind for the exam. I want to leave you with this provocative thought to really test your clinical synthesis. What if a patient who is actively taking a benzodiazepine, utilizing an intrathecal baclofen pump, and taking gabapentin suddenly shows up in the ER with a high fever and altered mental status? Which black box warning do you investigate first? Are they suffering from benzotoxicity, or is their baclofen pump malfunctioning, triggering a lethal withdrawal cascade? Think about the specific, distinct symptoms of each emergency we discussed today to guide your triage. Thank you so much for joining me on this explainer. Trust your assessments, you're going to do great, and I'll see you next time.